So I'm shadowing an orthopedic surgeon right now, and I just wanted to kind of go over the basics of some of the things that they'll bring up and they'll see. And so I want to start with something super basic to orthopedics, and that's cartilage versus tendons versus ligaments. So first, we're going to go over what each of them is, and then we're going to look at them together in a joint, and then we're going to look at this word that I came across, um, Ethan I just looked up how to say this word. Let's see. Let's see how they say it. Entheses. And then we're going to look at some clinical applications. So, first let's start with cartilage. Cartilage is a connective tissue. It helps to cushion impact. So think of a shock absorber. If you kind of like think about your car, the shocks on your car make it a smoother ride. And so the more cartilage you have, the easier it is. You don't have bones rubbing on bones because that can cause a lot of pain. Um, Cartilage is avascular and aneural, meaning um, it has no direct blood supply, and it has no nerves in it, and so that's why you can it's in between your joints and you don't feel that like compression of your cartilage. But when people get osteoarthritis, that's when the cartilage in the joint wears down, and they can feel that bone on bone because there's nerves in your bone, and that rubbing together, that's what hurts. And so that's why it protects bone on bone contact. So there's three types of cartilage. Your first type is hyaline cartilage. It's going to be light blue in appearance and kind of white. It reduces friction. It can withstand compression forces. You usually see this around your trachea, your nose, your epiphyseal growth plate, so at the end of your bones, your sternum, and the ventral segments of the ribs. So there's cartilage in between your ribs and your vertebrae, and so that's where that is. Next, you have elastic cartilage, which is going to be dull yellow, pressure resistant, and flexible. So this is going to be places like your ears, epiglottis and larynx, and even eustachian tube, which is the tube that's from your oral passageway, nasal passageway to your ear. And so when you think of elastic cartilage, you can think of the E's. So you can think of the ears and epiglottis and the eustachian tube. I mean, larynx doesn't have an E in it, but hopefully maybe you're only asked for 3 examples of where elastic cartilage is from. Next, you have fibrocartilage, which is dull gray or opaque in color. Large amounts of tension and compression. So again, they all have something to do with withstanding a force, reducing friction, pressure resistance, flexibility, compression against tension. But you can see how they're useful depending on where they are. So like elastic cartilage is more flexible, and so that's good for your ears. Fibrocartilage is going to be in your tendons, ligaments, intervertebral discs, some bones, articular surfaces, and the meniscus. And so that those are all places that you need to withstand a great amount of compression right between your knees. Think about when you jump and you land. It helps you to absorb that shock through your body, and so that's why it's really important to have it in these bones so they can kind of compress a little bit and then just absorb that shock through the different joints. So next we're going to talk about tendons. So these are the muscle to bone or bone to muscle connections. So think about when people say your quad tendon, right? It's connecting a muscle to a bone, and it helps to distribute the force generated by the muscle. So your muscles can contract, but we need something to apply that force to the bones, and so those are your tendons. So they have tensile strength. The tendons fibers are not just seen at the ends of the muscles, but they're seen throughout the muscle. And the transition is the myotendinous junction. So when you think of like a muscle and it, there's this tendon and it goes to a bone, it kind of all looks like this, right? This is that myotendinous junction where it goes from the big muscle to the bone. And so you strain tendons. So there's the sprain or strain. And I think there's a T in strain. So tendons are what you strain, ligaments are what you sprain. So it's very similar, but they're different. So you can think you can strain your back, your neck, your hamstrings, your calf. And this can feel like weakness, spasms, or cramping. Those are kind of your symptoms of the strain. Next, we're going to talk about ligaments. So ligaments are bone to bone, and even organs to bone. So you can have some in your with your different organs holding your intestines and your stomach and all those things where they're supposed to be. You can think of your ovarian ligaments keeping your ovaries and your uterus all attached together. So these help to stabilize joints and help keep bones aligned. So imagine if we just were able to generate force on muscles and we didn't have anything to keep our bones aligned where they're supposed to be. So that's where ligaments come in. So they're sturdy and tough bands of connective tissue. You can sprain a ligament. So there's a T, tendon starts with a T, strain has a T in it. So then the other one is a ligament sprain. And you can sprain your ankle, wrist, other joints. This can be seen, the symptoms, this would be bruising, instability of the joint, and trouble weight bearing. But ligaments are super important. You can think of your ACL, MCL, PCL, all the different ligaments in your knee are things you can sprain or tear. So now I wanted to look at a joint with all of these working together. So here you have the knee joint. I've tried to kind of label everything. You have your tibia, you have your fibula, you have the femur up here. So you can see, so the meniscus are that cartilage, and you also have articular cartilage. So as the knee bends, this kind of rubs the whole way up against the meniscus, as you were to flex your knee and make that angle smaller, you'd have cartilage rubbing the whole way, so you would have any pain with that. Then you have over here the patellar ligament or tendon. Technically, I do think it's a tendon because it goes over the entirety of the patella, but some people call it a ligament, some people call it a tendon. I think usually, because you can see how it attaches the patella bone to the tibia bone, but for the most part, since it's a continuous tendon over the patella, most people call it a tendon. Now this enthes is an interesting word I came across. Still not 100% sure how to say it. I guess we can maybe listen to it again to see how to say it, because I don't know why this one. Let's see here. I don't know why this one gives me so much trouble. We'll just try to say enthes is a connective tissue between ligaments and bones or muscles. And so it's kind of just describing this zone of change here. And so I want to go over what this kind of means. So right here we have a ligament in the knee, and we've drawn it into zones 1, 2, 3, 4, and the tide mark. And the tide mark is where it changes between cartilaginous fibrocartilage to calcified fibrocartilage, so kind of turning into bone. But that's the tide mark. You can see it's really clear when you see it on a microscope or something. And so the different zones. So the first zone is parallel collagen fibers and longitudinal fibroblasts are in the tendinous areas. Also fibroblasts, if we could think blasts build and clasts cleave, and so fibroblasts are building those fibrous cells. And then zone 2 and 3 is an area where the fibrocartilaginous is an area of fibrocartilaginous where fibroblasts change into chondrocytes. This is cartilage and cytes cell. So turn into cartilage cells. So we have the fibrocartilaginous cells where the fibroblasts make them into cartilage cells. So then you have the tide mark or the blue line, which is where there's a sudden change between cartilaginous fibrocartilage into calcified fibrocartilage, so it's a little bit stiffer. And then we have zone 4, which is the bone. Now, some clinical applications, we're not going to go into depth about any of these, but just some things to think about. Osteoarthritis is important because, like we said, you can maybe see, sometimes you'll see x-rays of bones. It'll kind of look like you kind of have the knee joint, and then kind of the top of the tibia. Can make it a little bit better. And they're right on each other. And so that rubbing is what's causing pain. Whereas if you see a nice x-ray, it should kind of be, cartilage doesn't really show up on x-rays. So there should be some space in between those bones. And so osteoarthritis is when there is no space between those bones, and that's causing inflammation, pain, and swelling of that joint. So some treatments. We can do a steroid injection, which will kind of help with that inflammation and kind of calm it down. It can be anywhere from a couple weeks to a couple months. And so let's say you have, right now we're seeing some people in clinic with some really bad osteoarthritis. I mean, their x-rays look like this. They are going to need knee replacement, but thanks to these steroid shots, let's say you need a couple more years to come up with the ability to be able to take this surgery. Let's say your diabetes is not under control. You have a heart condition that you need to be seen for. Or things even like your insurance. You're going to need to get approval from your insurance, and that could take some time. So that's why these steroid shots can really help, because let's say we gave you a steroid shot, and they gave you 6 months of walking on that knee without a knee replacement. That can be really important in getting things arranged, so that time is important. Usually 2 to 3 months before knee replacement surgery, we like the steroid shot to be a couple months out. So let's say like if I got a steroid shot, we're not doing the knee replacement for a minimum of 3 months from when the steroid shot was given, because that can just lead to an increased risk of infection with the knee replacement. So we just like to increase our chances that everything goes well. Additionally, anti-inflammatory medication, so Advil, Tylenol, your NSAIDs. So that's not how you spell NSAIDs. Let's see here. Non-steroidal anti-inflammatory. Man, I don't remember what that T stands for. Let's see here. See what NSAID stand for. One second. Here we go. Okay, so non-steroidal. Oh, okay, there you go. Anti-inflammatory drugs. Perfect. So the extra S is not. It's just not. Okay, there we go. Then, okay, once we've taken our time to figure out when we're going to best do this surgery, have everything under control. We have family there to help, with the rehab process. we can do a replacement or resurfacing of that joint so it can help with the osteoarthritis. There are some joints, so let's say you have some problems in your, let's say you have like arthritis in your thumb or something, osteoarthritis or something. Sometimes orthopedic surgeons don't like to give injections into those spaces because it's kind of a small space. It's a small joint space, and it kind of doesn't really you don't see the huge benefits like you would in the knee or the shoulder joint for some of those injections. So, depending on the joint, some of these treatments could be better or worse, but these are kind of for big joints. So then we can also have spinal disc herniation, which is a degeneration of the intervertebral discs caused by a disease. So annulus fibrous is a disease that can cause, or I believe that's what this degeneration is called, but that's, you can have that. So usually if you think about, you got your little bony protrusions, whatever, coming off of the spine, you have your discs, usually there's a good amount of space between them, this is all cartilage, but sometimes, same thing with your other joints, you can have this space between them, and it's not a lot of cushion. It can cause some pain. And you can see these anywhere in the spine. So let's say you have really poor posture, you can see them in the cervical spine. Just general wear and tear and age. The thoracic spine, the lumbar spine. So that can kind of be seen anywhere in the spine. Just depends on your lifestyle, and things like that. So now some treatments would be lifestyle change, anti-inflammatory medications. So again, if your posture is really poor, if we improve your posture, that can relieve some of the tension between your vertebrae. Again, the NSAIDs, those are super helpful. And then some other conditions, you can have traumatic rupture or detachment of tendons or ligaments. Achondroplasia, so A meaning without, and then chondro meaning cartilage, and plasia meaning formation or development. Can make that better. Okay, development. And so this is, you could see it with without cartilage formation, and so it can be describing a genetic bone growth disorder. So you see this a lot with people with dwarfism, because the bones and the cartilage aren't forming correctly, and then you can have costochondritis or a neoplasm. So we're not going to go super in depth with all those conditions, but just know that these are some conditions that can affect ligaments, tendons, cartilage, and so on. I hope you found that interesting. I thought it was cool. Yeah, good luck studying.